everybody can see my screen and hear me at this point. So thanks for having me. My name is Amr Zaidan. I'm professor of medicine, as you heard, associate professor at Yale University. So these are my disclosures. I will be talking today about um, management of lower risk MDS. So I would start basically by describing what is MDS and understand the symptoms, the signs, and the diagnosis of MDS, as well as review the outcomes and how do we classify lower risk versus higher risk disease. And finally, understand the management options for lower risk MDS, including those approved therapies as well as the ones that are currently in clinical trials. So many of you might be familiar with what MDS means. However, it's actually a vague term even for many clinicians because it's not really one disease entity. And this is why I typically would refer to MDS actually in plural, so myelodysplastic syndromes, because it's a heterogeneous group of malignant hematopoietic conditions. So there are some features that are present in every kind of MDS, which include bone marrow failure. So bone marrow failure means that the bone marrow is not doing its normal function. The bone marrow is like the kidney, the liver. It's an organ that performs a certain function, which is to make blood cells. Those include the red blood cells, the white blood cells, and the platelets. And when the bone marrow failure is used, this is a term that means that the production of the blood cells is abnormal. So this is related to abnormality within the immature blood cells, which I would call the motherships that make the other blood cells. And they are basically not maturing normally and they are dying within the bone marrow. And that leads to low number of blood cells in the blood. So patients usually will have low blood counts, which could be in the red blood cells, what we call anemia, in the neutrophils, neutropenia, or in the platelets, which are what we call thrombocytopenia, or a combination of these. I think it's important to understand with MDS that there are a number of conditions that could mimic MDS. And I'm showing you a listing here of those conditions and some overlap of those circles because sometimes it's difficult to actually distinguish MDS from some of the other conditions such as aplastic anemia or myeloproliferative neoplasms or even sometimes acute myeloid leukemia. So I think it's very important that you talk to your doctor and make sure that the diagnosis is indeed MDS because the management and the prognosis is different. And sometimes it's actually very recommended that you get referred to an expert in MDS because sometimes distinguishing these entities can be quite challenging. And this is another way of showing the same idea. How many conditions can actually mimic MDS? So I showed you earlier some of the blood cancers that can look like MDS or some of the blood conditions, but even other conditions can look like MDS, like immune conditions. For example, some patients with lupus or some patients with rheumatoid arthritis, some patients who have inflammatory bowel disease, they could have changes in their bone marrow and low blood counts that look like MDS. Again, very important to differentiate if this is truly MDS, especially in lower risk MDS, because the treatment is very different. If, for example, like a picture of low blood counts is related to lupus, the treatment would be directed at the underlying condition, which is the lupus or the rheumatoid arthritis, rather than doing MDS type of therapy. Similarly, medications, for example, some antibiotics, some drugs used to treat some of those conditions, such as methotrexate or azathioprine, certain heavy metal poisoning, lead and zinc, alcohol abuse, all of those can cause a picture that looks like MDS in the blood and the bone marrow. Also, similarly, certain nutritional deficiencies in B12, in folate, in copper, some of those also can look like MDS. So I think the bottom line is that sometimes it can be tricky to diagnose MDS, and there should be a very thorough workup and often referral to a specialized center. So MDS basically is a condition that mostly affects older patients. We can see it on occasion in younger patients, but as you can see in this diagram, that most of the cases occur in patients who are 70 years and older. Actually, the median age, which is the age at which half of the patients would have MDS, is in the early 70s, 71 to 76. And it's a relatively rare condition. Around 20,000 people are diagnosed with MDS a year. and it can become more aggressive in some patients where it can progress to acute myeloid leukemia, and this happens in around one-third of patients. So you might hear that you have what we call a de novo or idiopathic MDS or secondary MDS. So what does that mean? De novo means that MDS arose without any previous certain predisposition, meaning that the patient did not have a specific reason to have it. And that's actually the most common situation. 80 to 90% of cases, it's de novo or idiopathic. In around 10 to 20%, it's secondary. And there are two large groups of secondary MDS. One group is related to previous therapy and what we call therapy-related MDS, and that's usually the result of exposure to previous chemo or radiation to another cancer, such as breast cancer or prostate cancer. And after some years, because of the DNA damage, some of those patients can develop MDS, what we call secondary or therapy-related MDS. And then there's a group of MDS that arose from congenital conditions that predispose patients to blood cancers, such as Down syndrome, etc. So what are the symptoms of MDS? Sometimes there are actually no symptoms and the patients are diagnosed just based on routine blood work. I often see patients in my clinic who are referred for a new MDS diagnosis that was picked up when they had a routine blood work during a routine physical exam, sometimes during a preoperative evaluation, and they noted that the patient had low platelet count. While other times the patients could have symptoms which depend on the degree of the cytopenia, the low blood count. For example, anemia can cause fatigue, pallor, shortness of breath, chest pain, and anemia is actually the most common presenting symptom for MDS because it occurs in more than 80% of patients. Neutropenia, the low neutrophil count, can result in recurrent infections, which can be severe, while thrombocytopenia, or the low platelet count, can cause early bleeding or easy bleeding, or bruising, especially from the gums when you brush your teeth, from the nose, what we call petechiae, which are small red spots that occur under the skin when the platelet count is low. So all of those conditions basically can be manifestations of how MDS presents. So the diagnosis,
excuse me, Dr. Zaiden, for just a moment. Could you switch your? You are in the. You're not in the presenter. You're in the presenter mode and not the slideshow mode. So we're seeing the next slide on the screen. If you could just change it to the full screen.
Sure. Okay. Sorry for that.
There we go. Thank you.
So how do we actually diagnose MDS? We diagnose MDS by the medical history, by the physical exam, but also by an extensive array of blood tests, as we discussed, including assessment for nutritional deficiencies, assessment for copper and other rare iron, metal deficiencies, as well as often doing a bone marrow biopsy. Some of you might have had a bone marrow biopsy and an aspirate, and we do a number of studies. So this is an example of how a bone marrow biopsy is done. So we go with a needle. We usually make sure we apply a very good antiseptic technique so that there will be no infection introduced. We clean the area very well, and then we go with a needle, often called Jamshidi needle, but there are other ways. And as you can see here on the diagram, you go through the thick part of the bone into the marrow, which is the material that's between the edges of the bone. And then you take a sample. We take two samples. One sample is the liquid sample called an aspirate, and another one is called the biopsy. And we do a number of assessments on them. We look at those under the microscope. We do run studies called flow cytometry, cytogenetics, and molecular diagnostics. And I'm going to show you some examples of that. So this is an example of a karyotype, which is a representation of the chromosomal abnormalities that we can see sometimes in MDS. So normally, each one of us has 46 chromosomes. They happen in pairs. And here is an example, as you can see in the red circle. This patient had an extra copy of chromosome 8, which is something we see in MDS, but it's not diagnostic. It can happen in other conditions. So that's an example of trisomy 8. You might see in your records or hear from your doctor that you have trisomy 8 or monosomy 7. Monosomy means that you have only one copy rather than two copies. You might hear that you have complex karyotype. Complex karyotype means that you have 3 or more abnormalities. So that the way we decide on this is by doing this test, the karyotype, either from the blood or more commonly from the bone marrow sample. Another test that you'll often hear about is FISH, or fluorescent in situ hybridization. This is again another way of looking at the chromosomes. However, this test is more specific, meaning that you have to use a specific probe to look for any specific abnormality. So here the probe looks for abnormalities in chromosome 8, chromosome 21, and then you can reach the same result, is that you have trisomy 8. So in addition to the molecular in addition to the cytogenetic studies, we look under the microscope for evidence of what we call dysplasia, which is abnormal maturation of the cells. And then we combine all of these, basically the dysplasia in the bone marrow, the low blood counts, the cytogenetics, and then after we rule out other conditions, we make the diagnosis of MDS. But then the next question becomes is, what is the risk category of this MDS? And how can we go about treating the patient? So a very important step is calculating what we call the risk score, or the prognostication. And there are a number of ways to do that. You might have heard about the FAB, the French American British classification. This is actually old and no longer used. However, some of those terms might still appear in the literature, and sometimes even on the drug approval labels. There is the WHO-based prognostic scoring system. There is the International Prognostic Scoring System, and then there is the revised IPSS, or the revised International Prognostic Scoring System tool. So as I mentioned, this FAB classification is still something that is seen in the literature, although now it's largely of historical interest. But some of those terms you can still see in your records and in the literature, such as refractory anemia, which refers to the anemia. The reason why it used to be called refractory, because before MDS was recognized, they used to treat anemia by liver supplement and other nutritional supplement, and then if it's from iron deficiency, the anemia would improve. But in MDS, it would not improve, so it used to be called refractory anemia. Now, clearly, we have treatments for this anemia, so it's not necessarily refractory anymore. And there's refractory anemia with ring sideroblast. There's refractory anemia with excess blast. And there's refractory anemia with excess blast in transformation, although again, this term is no longer used. And then there is CMML, or chronic myelomonocytic leukemia, which now is no longer classified as a subtype of MDS. It's what we call an overlap condition. This is a very busy slide. Again, here the intention is to show you how some of these scoring systems are calculated, as the IPSS, the revised IPFS, the WPSSS, and the MD Anderson classification. So in each one of those, you add in the numbers together based on the blood counts, based on the number of the blast, and based on the cytogenetics, and then you come up with a score. And that score, as you can see at the bottom of these tables, for example, if you look at the revised IPSS, you can see that there is very low, and those are what we call lower risk MDS, and then high and very high, and this would be high risk MDS, and then you have intermediate. Intermediate can belong to lower or higher risk MDS depending on a number of variables, and I think it's important to discuss with your doctor whether you are within the lower or the higher risk disease. So I showed you cytogenetics, but now we are doing a lot of what we call genetic assessments as well. We are looking at the alterations in the DNA and to look for mutations, as you can see here. So this is a much higher resolution type of assessment than looking at the chromosomes. And what we are looking for is somatic mutations. Often when we talk about mutations, people think of germline mutations, which are the mutations that can pass between parents to their children. What we often mean when we talk about genetic mutation in MDS is a somatic mutation, which means it's acquired. So it's only present in the bone marrow. It's not present in your other cells. And it's not something that you generally pass to your children. However, it's something that is important to recognize, because now it's affecting how we understand the disease and could be potentially a target for new therapies. And since the recognition in around the year 2007, of some of those abnormalities, the number of abnormalities has increased significantly. So you can see here a representation of some of those abnormalities, and the size of the circle basically correlate with how often do we see this abnormality. For example, the biggest one, the TET2, DNMT3A, and ACXL1 in green, those are the most common abnormalities seen. Some of these, for example, having TP53, are associated with worse outcomes than some of the others. For example, having the splicing mutation SF3B1 in black, this one is actually associated with better prognosis. And some of these could be also targets for intervention. For example, SF3B1 could be a target for a drug that we'll talk about a little bit called luspatercept. IDH1 and 2 also could be treated with IDH inhibitors, although those are not approved for MDS, but they are approved for refractory leukemia in patients who have these mutations. So now that we have made the diagnosis, we have decided on the risk group, and we decided that the patient has lower risk MDS. How do we go about treatment? And here, one of the other speakers today, I think, will be talking about management of higher risk MDS. So the rest of these slides are going to be focused on lower risk MDS. So the treatment options basically for MDS in the lower risk version include maintenance of quality of life. And generally, we don't have therapies for lower risk MDS that can cure the disease aside from bone marrow transplant. However, because bone marrow transplant can carry significant risks, for patients with lower risk MDS, we generally will not recommend bone marrow transplantation and rather manage the patient by interventions that can maintain quality of life. Ideally, if you can improve overall survival, although still we do not have therapies that do that, and avoid complications such as infections. And the treatment is decided based on a number of factors, based on the risk group that we discussed, the age, the performance status, which is a measure of the functional capacity of the patient, as well as their comorbidities, medical problems that they might have. So what about anemia? Anemia is the main problem in MDS. More than 80% of patients will have anemia. Most patients will need red blood cell transfusions, and the frequency can vary. Some patients might need them every 3 months. Some patients might need them more frequently. Some patients might even need them as frequently as 1 to 2 units every week. And the transfusions can improve symptoms and make the patients feel better, but not in everybody. Some patients, when you transfuse them, they might not necessarily feel much better. So it varies from one patient to another. However, chronic transfusions come with certain risks because iron is present in the blood, and there is no way for the body to get rid of the iron normally. So a lot of transfusions can lead to accumulation of iron, and that can cause problems. So generally, patients who require a lot of transfusions also tend to do poorly and have worse outcomes than the ones who do not need a lot of transfusions. So a lot of the management that we focus on are trying to get what we call transfusion independence, meaning that we are hoping to make the patient stop needing transfusions as a big part of the intervention. There are certain things that you also can do to manage your symptoms. You can see some of those on the slide. For example, the fatigue that comes from anemia, trying to make sure you sleep well at night, exercise as much as you can, take short walks, don't do everything on your own, allow other people to help with tasks, and try to get like naps and rest periods throughout the day. All of these things can help. Same thing for bleeding that can happen from the low platelets, basically. Use a soft toothbrush because often patients might have gum bleeding if they use a strong toothbrush. Try to avoid flossing if the platelet count is very low. If you shave, don't use a razor and try to use an electric shaving machine. And try to be careful about falling and clutter because if you fall with very low platelets, you could have bleeding, which could be significant. So all of these are important interventions. The same thing for infection because of the low neutrophils. Good hand washing. Now, during the COVID pandemic, many of us continue to wear masks, and I would encourage most patients with MDS to continue to wear masks because even if you are vaccinated, your immune response might not necessarily be as good as patients who have healthy immune system. And try to minimize basically if you have very severe neutropenia, very low counts, try to minimize like mixing with patient with crowds and people who might be sick. And sometimes your doctor will ask you to take antibiotics to prevent occurrence of infection. And if you are eating outside your home, make sure you eat in places that are very clean, and basically, and the food is avoid raw foods like raw fish and things like that. And everything should be well cooked and well washed. And finally, you should check your temperature. And if you have a fever, very important to call your doctor, because we often will recommend patients who are neutropenic, who have a fever, to get intravenous antibiotics and be admitted to the hospital, because infections can progress very quickly. So all of these are very important precautions. How about actual drug intervention? This is again a complex slide, and it's actually better for us that it's getting more complex, because it means that there are new treatment options that keep coming up. I'm going to go through some of those treatment options, but the point of this slide is that there is no single one treatment that used for every single patient with MDS. A lot of the treatments are adapted to the particular situation. As I mentioned, what is the main problem? Is it the low hemoglobin, the low platelets, the low neutrophils, and some of the other blood tests that we run to decide on the best treatment. So one common option is what we actually watch and wait. And that means basically that if the blood counts are not super low and they are not causing problems, and since we cannot cure MDS without a bone marrow transplant, sometimes we just monitor the patient and only treat them if the blood counts become low enough that they cause problems or they cause symptoms. Another thing we often do is basically supportive measures such as blood transfusions. As I mentioned, some patients might only need a transfusion every 3-4 months, so they might not necessarily need to be treated. But if the transfusion frequency becomes more frequent, then we would want to treat that. And then you have a listing of some of the drugs that we use. I'll talk about some of these in the next few slides. EPO, or what we call erythropoietin stimulating agent or erythropoiesis stimulating agents, hypomethylating agents such as azacitidine, decitabine, immunomodulatory agents, immunosuppression, as well as chemotherapy and trials. However, chemotherapy and bone marrow transplant, as I mentioned, those are generally reserved for patients who have higher risk or more aggressive forms of MDS. How about ESAs, or erythropoiesis stimulating agents, basically? So those are the most common treatment for patients who have anemia from MDS. They can help with the symptoms when the hemoglobin goes up, and in some patients they can cause transfusion independence, so you don't need transfusions anymore. They work in around 40% if you take everybody with MDS who has anemia. So not everybody will respond to these, and they can be slow to work. So they should not be used only for 2-3 doses. They should be used generally between 2 to 3 months before we say, well, they are not working, because some patients might need as long as 3 months before they start responding. And there are different versions of these ESAs. There's a short acting and long acting. The short acting is Procret, and the long acting is called darbepoetin. And those are given usually as a subcutaneous injection, and they can be given as frequently as once a week. But with the long acting ones, such as darbepoetin, they can be given every 3 weeks. And generally they work better if you are not needing a lot of transfusions, or if your erythropoietin level, which is the indigenous hormone that helps red blood cell production, is less than 500. If you are needing a lot of blood transfusions and your EPO level is more than 500, it's unlikely that ESAs would work, and your doctor might consider other treatments or clinical trial. Another agent that has been approved also for many years now, really, since 2005, is lenalidomide. Lenalidomide basically is a pill. It works particularly well in patients who have deletion 5q. This is a subtype of MDS in which you have deletion 5q. We used to think of lenalidomide as an immunomodulatory agent, but now we know that the mechanism of action is actually much more complex, and it works particularly well for patients who have deletion 5q. the response rate in terms of causing patients to stop needing transfusions is close to 67%, meaning out of 3 patients, 2 will stop needing transfusions with this drug. However, it does not work as well in patients who do not have deletion 5q. Sometimes we try it, but the response rate is shorter and the duration of the response is also shorter. This is a pill that's taken once a day, and the most common side effects is in some patients can cause fatigue, can cause rashes, some GI upset, and it can lower the other blood cell counts. So while it might increase the hemoglobin, it might lower the neutrophils and the platelets. Another drug, this drug, luspatercept, was actually just approved last year. So this is basically a new first-in-class agent. We refer to it as an erythroid maturation agent. So it actually helps the red blood cells mature to full red blood cells and not die in the bone marrow by targeting a pathway called transforming growth factor pathway. And this was shown initially in a phase 2 trial to be very helpful to some patients where the response rate was around 40%, causing transfusion independence. It was noted in this trial that patients who have the ring sideroblast, you might recall I told you there are some patients who have ring sideroblast. So those patients respond particularly well to this drug, which is again is given by subcutaneous injection, and it's as you can see here, it's a modified antibody. So this drug has been tested basically in a large study called the Medalist trial, which is a randomized phase 3 trial, and based on the results in anemic patients with ring sideroblast, the response rate was around 40% transfusion independence. So the drug has been approved and now it's available in the US. So this is something that we consider after ESAs, erythropoiesis stimulating agents, don't work, or after they stop working. So it's not approved as a first-line treatment. There is currently ongoing trials looking at this drug as a first-line treatment, but the current approval is after ESAs or in patients on whom ESAs are not likely to work. Another important thing we talk about is iron chelation. As I mentioned, iron can accumulate in the body and can cause problems for patients. And this iron accumulation, basically because the body cannot get rid of the iron in its own. So there are certain medications that we can use. You might have heard about deferracerox or deferriprone. Those are agents that are taken by mouth. We use also to use an IV drug, but it requires very long infusion every night, so it's very rarely used in MDS. And there is some controversy about the use of iron chelation therapy in patients with MDS. But for patients who have lower risk MDS and who are needing a lot of transfusions, I think it's something that has to be considered very carefully by the doctor, especially if the patient is having like more than 20 units of blood in their life, because the risk of iron accumulation becomes higher. So that's something you want to talk to your doctor about. I did not talk about hypomethylating agents such as azacitidine and decitabine, because those are generally used for management of higher risk MDS, although sometimes we use them also for lower risk MDS, but it's something that also will be covered during the subsequent talk about higher risk disease. So in conclusion, I think it's very important for patients and their families to understand the disease. They particularly need to make sure that MDS is the correct diagnosis, to know their blood counts, their blast counts, and their classification, as well as their IPSS or revised IPSS risk category, and whether they have lower or higher risk MDS, and to understand the available treatment options and the risks and benefits of different therapies and the role of bone marrow transplant. So there are many resources that are out there. The Aplastic Anemia MDS Foundation, International Foundation, is a great resource. There are other foundations, the MDS Foundation. There is the Leukemia Lymphoma Society, and there are many, I think, good online resources. So you are not alone, and you should always feel empowered to reach out and talk to also support groups about their experiences, and many people are there to help. So I would like to thank the organizers again for inviting me to talk to you today. And this is my email as well as my Twitter handle for any questions. Thank you so much.
Thank you, Dr. Zaiden. We do have a few questions. The first one is, my hematologist oncologist is considering having me begin taking Neupogen. What are the implications or risks of beginning this therapy in the short, intermediate, and long term? Should patients work to delay beginning Neupogen therapy as long as we can?
Yeah, that's a good question. So I think Neupogen is a growth factor that helps stimulate the neutrophils, what we call GCSF. So generally, we don't think of this as a good treatment for patients who have low neutrophils because the literature is not very strong that it reduces the risk of infection, and there could be risks about using it on the long term. It's more theoretical that it might increase the progression of the disease to more higher risk forms. However, the main use of Neupogen in MDS is actually to help in certain situations the anemia. So there is some literature that adding Neupogen to erythropoiesis stimulating agents such as ESAs can actually increase the red blood cell production and improve the anemia. That's in particular for patients who had ring sideroblast. I think with the availability of other drugs like luspatercept, it's now we have a better option for patients who have MDS with ring sideroblast. I rarely use Neupogen, and I would say only in situations where there might be an overwhelming infection that is very difficult to control with antibiotics. But generally, it's not something I would use chronically in most patients, and certainly not for neutropenia by itself. So I think this is something you want to discuss carefully with your doctor and maybe consider a second opinion.
Thank you. Our next question. I had two MDS specialists that have different opinions of the use of the medication Xjade for iron overload. What is your opinion of the use of this drug therapy?
Again, that's a very good question, and I think that speaks to the controversy that I alluded to in the last slide about iron chelation therapy. So for lower risk MDS, and I'm assuming what the patient has is lower risk disease because we do not typically use it for higher risk, but it's more for lower risk. For lower risk disease, if the patient has received a lot of blood transfusions or is expected to receive a lot of blood transfusions, um, or if the ferritin level, which is a measure of the iron in the body, are high, we discuss the use of iron chelation. Now, iron chelation, again, comes with some risks. It can affect the kidneys. It can, in some patients, can cause GI upset. Rarely, it can cause more severe conditions such as GI bleed or renal failure. So it's something that has to be discussed in the particular situation of the patient. Like someone with history of GI bleed or someone with kidney impairment, I might be more hesitant to use it. So I do think it's ultimately a decision that has to be taken based on risk and benefits. And this is why there could be differences in opinion between different experts in how they view the data and the particular patient situation.
Thank you. Next question is, would you recommend the shingles shot for MDS low risk patients?
So in general, I think with all patients with blood cancers, our preference is what we call inactivated vaccines. So we generally prefer not to that the patient does not get any live vaccine because live vaccines in someone whose immune system is weak and can cause problems. So in general, any vaccine, and I can't recall for the shingles, I think there are variants or like there are vaccines that are inactivated or not live viruses. If that's the case, I think it's fine. But for any kind of live vaccine, I would try to avoid.
Thank you. Next, I've seen recently that there has been a change in the subtypes of MDS. I was diagnosed with RCMD RS, but I saw that it has changed, but I don't know where to find the new subtypes.
Yeah, so actually, I showed some of the older classifications, but the RCMD means refractory cytopenia with multilineage dysplasia, and the RS means ring sideroblast. So this used to be called in the past RARS. I showed that refractory anemia with ring sideroblast. Actually, RCMD RS is still currently used, and that usually means that you have the ring sideroblast. So, from a practical point of view, if you are in the lower risk category, if you have that and the main problem is anemia, this is one of the situations where luspatercept could be used for anemia. Other options could be erythropoiesis stimulating agents if the APO level is low.
Thank you. Our next question, should a low-risk 75-year-old in good health and no comorbidities who is transfusion dependent every 2 to 3 weeks that has not responded to any treatments including HMAs and a clinical trial consider a stem cell transplant or stick with transfusions?
Yeah, that's again a very good question, and I think it depends on the details of the health of the patient. So in general, chronic transfusions and lower risk MDS, if the patients do not respond to any therapy, including hypomethylating agents, the survival in general, if you look at the average survival, is based on studies is less than 2 years, although it's lower risk MDS. But after hypomethylating agent failure and failure of the other agents, it becomes a challenge. Generally, chronic transfusions for a very long time is not a very good option. So if the patient, let's say someone was in like exact same situation you told me, was in their 60s, I probably strongly recommend bone marrow transplant as long as the patient can tolerate it and they are in good shape. If the same patient was in their early 80s or let's say 79, I probably say that transplant is not practical in most places because of the age, even if the patient is in good shape. The patient that was mentioned in this case, 75, is around the age where we actually do consider bone marrow transplant. In my institution, we certainly have performed bone marrow transplants in patients who are 75. So I think if the patient undergo the transplant testing and their organ function is okay, and we determine that they can tolerate transplant, we would consider transplant in this situation. But again, it's a decision that involves understanding the risks and the benefits of the transplant as well as the patient goal, because here you are trying to gain long-term survival at the expense of increased potential toxicity on the short term from bone marrow transplant, including risk of death. So I think at the very least, the patient should talk to a bone marrow transplant specialist about the risks and benefits from the transplant.
Thank you. When first diagnosed with MDS, is it wise to get a second opinion?
Yes, and I strongly recommend that for a number of reasons. One of them is that the field is actually changing very, very rapidly. For some time, we had some stagnation in the MDS kind of trial approvals. As I mentioned, we only had some drugs approved in 2005 and 2006, and since then, we did not have any drugs approved until the year 2020. In 2020, we had two drugs approved, luspatercept and Inqovi, which is an oral version of decitabine. And now there's a large number of clinical trials that are actually ongoing. A lot of these drugs are in advanced clinical testing. And I do think there is increasing number of agents. So I think a number of reasons basically to see a specialist would be to confirm that the diagnosis is truly MDS. Because as I mentioned, there could be situations where the diagnosis is uh, somewhat tricky, and I think expert opinion could help. The second reason is to consider bone marrow transplant because I had patients who have higher risk MDS in which transplant is indicated, have been told by their local doctors that because they were in their 60s, that transplant is not an option. Although now we can transplant patients up to their mid 70s as long as they are otherwise in good shape. So I think it's important to realize that being in your 60s doesn't mean you cannot have a transplant. You should really talk to, again, an expert in MDS as well as a transplanter. A third reason is to consider clinical trials, because many of those agents that we just discussed, sometimes they don't work. If they work for a limited time. So there could be clinical trials as a first line treatment that are actually very good for the patient in terms of how they can help. So I do think for all of these reasons, I think it's a very good idea that the patient is either referred, or at the very least their doctor calls, an MDS expert and kind of checks with them about any new trials. Or and this is how I generally do it in in Connecticut. A lot of the local oncologists. You have to remember that MDS is not like breast cancer, lung cancer. It's not a cancer that the local doctor sees like many cases. Most local community oncologists probably have 5 patients a year or something like that. It's not common. So they don't have the same degree of experience like they would have in some of the more common cancers, such as lung or breast cancer. So I think it's always good to confirm with a specialist in those situations.
Thank you. Our next question is, what are the best first medications to use for neutropenia and low neutrophil counts?
That's a, that's a very good question. I think in some patients with lower risk MDS, and I touch on this at the end, is we don't have very good drugs that treat neutropenia. So we often, if the main problem for the patient is neutropenia and it's causing infections and problems, even if they are lower risk, we consider use of hypomethylating agents such as azacitidine or decitabine. However, there are some patients with MDS, with lower risk MDS, who have low neutrophils and can stay like that for years without problems. So it really depends on the patient. Are they deep? Like how low is the neutrophil count? Is it very low? Is the patient having recurrent infections? And also, how what's the goal of the care? Because in a younger patient, someone with deep neutropenia for MDS, even if they are lower risk, I would consider bone marrow transplant in that situation. So I think all of these factors have to be considered. But in addition to the standard treatment, as I mentioned, sometimes we use preventive measures like preventive antibiotics and all these other measures to reduce the chance of infection.
Thank you. And another related question, medication related question. What are the best first medications to use for thrombocytopenia and low platelets?
Yeah, that's another good question. So I think it depends on whether the thrombocytopenia is coming in the context of low risk or high risk MDS. If it's part of a high risk MDS, we often would recommend going to transplant, and sometimes the patient would need azacitidine or decitabine, the hypomethylating agents. If it's part of the lower risk MDS, meaning that the patient has like not no increase in the blast, and the chromosomes are not in the category of bad cytogenetic abnormalities, it depends on how low the platelet count. So if the platelet count is not super low and it's not causing problems, sometimes you might observe the patient. However, if the platelet count is low, and generally in my practice, I would treat someone who has a platelet count of less than 50 who's having bleeding, or someone who's less than 30, because at that point, less than 30, especially if you get to less than 20, people can start developing like spontaneous bleeding, and sometimes could be life threatening. So what I would do is usually, again, depending on the situation, hypomethylating agents, because they can improve the platelets in some patients. Another approach, which is an off-label use, is the use of eltrombopag, which is a pill that can help the platelet count, but it's not approved on label for MDS. It's approved for aplastic anemia and ITP, idiopathic thrombocytopenic purpura. However, this drug can increase the risk of fibrosis in the bone marrow, and there has been concerns which have not been substantiated yet, is that increased progression to acute leukemia. But in someone who's older, someone who has not responded to hypomethylating agents, and especially in someone who is not a transplant candidate, who has a very low platelet count that's causing problems, I generally would consider this drug, eltrombopag. I also sometimes add aminocaproic acid, which is an antifibrinolytic. So this drug does not treat MDS, but sometimes it can reduce the risk of the bleeding. So measures directed at reducing bleeding risk.
Thank you. And our final question. My mother was diagnosed with MDS last December. She just started needing chemotherapy 5 days a month for 6 months. Is this normal for early stages of MDS, or has it progressed? She also gets Procrit weekly.
Yeah, so I suspect that the treatment she's getting is a drug called decitabine or azacitidine, because those are given 5 days to 7 days each month. It's normal that the patient would need 4 to 6 cycles because those drugs are slow to act. You probably will hear more about this in the high risk MDS talk. Um, Generally, we use these for high risk MDS, not the lower risk MDS that I talked about today. But in certain situations, as I have alluded to earlier, if the other therapies stop working, sometimes we can use hypomethylating agents in patients who have predominantly neutropenia or thrombocytopenia as the main problem. Even if they have lower risk MDS, we would also consider hypomethylating agents. So it depends on the particulars of the situation, but generally we treat the patient for 4 to 6 months before we say a drug is not working. I generally would not recommend adding Procrit to hypomethylating agents if that's truly what she's getting, because we don't have a lot of data that about combining them. But again, I think it depends on the particular of the situation, and again, I would recommend talking to a specialist about that.
Thank you, Dr. Zaiden, for sharing your time and expertise with us today. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Be sure to visit the exhibit hall between sessions. The next educational session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 37 years. This concludes the session.